Okay.
Not everybody.
Good evening, everyone. We will just let some more people join us. So you're very welcome. So as you're joining us, if you could mute your microphones, that would be great, if they're not already muted. And you're very welcome to have your screens on or off, whichever you prefer. I'll just let some more people gather in. I think the numbers are beginning to stabilize there. So we'll get started and we will introduce what we're talking about this evening, and then I'll hand over to our speaker. So I probably met many of you last week. So my name is Dr. Mary Claire Kennedy, and I am helping the Irish Institute of Pharmacy at the moment with their webinar series. So it's very nice to meet you all, and you'll be seeing me every other Wednesday for the next few months as we work through a series of webinars. So thank you for joining us this evening. So this evening we are looking at the topic of transplant patient care. And this has been a topic that's been in high demand. We received quite a lot of feedback in recent months that this is a topic that is of interest to many different types of pharmacists, so those in patient-facing roles and non-patient-facing roles. And indeed, from the feedback we received just prior to this presentation this evening, we can see that the vast majority, in fact, all of you, frequently come across these types of patients and have questions about their optimal care. So we hope that you find this webinar useful this evening. So just in terms of the domestics, as we say, your microphones are muted, and that just allows us to manage the webinar. But if you have questions, please do just type them into the chat box, or if you want to wait till the very end and you can put up your hand and you can unmute yourself, that we are very welcome to do that too. We are recording this presentation, and so it will be posted to the website in due course. So keep an eye out for that if you want to listen back to it again. If you're having difficulties at any time, the classic thing to do, turn it off, turn it on, and hopefully that will work. But we do have Audrey sitting here as well in the background to support with those kinds of issues. So she can facilitate any issues you're having or resolve them, hopefully. But as I say, the recording will be there anyway. Okay, and then we will circulate a feedback survey at the end as well. So we welcome any comments you have, and also any feedback you have for future webinars. We would much appreciate that. We're always looking to learn about what you're interested in. So our speaker this evening is Professor Patricia Ging. So she is, we're delighted to have her here this evening. She's clearly the expert on this subject area, and will hopefully share lots of her wisdom this evening. And so please do, if you have any questions as you go about the content, please do type them into the chat box. Patricia will either take them as she goes, or we can corral them all up to the end. We'll see how the flow of the evening goes. Okay, so I'll hand over to you, Patricia. Thank you very much. So Patricia's just going to share her screen now, so just bear with us for a moment.
Okay, I think that's good. Is it?
Yeah, that's perfect. Yes, thank you.
Okay, so thank you for the introduction. And also, thank you all very much for coming tonight. I'm so impressed that so many of you were interested in hearing about transplantation. It's something that's obviously very dear to my heart. Now, it was nice for Mary Claire to say that I'm the expert. I'm only the expert in heart and lung transplant. I think my colleague Jennifer from St. Vincent's Hospital is also on the webinar. So if there's specific questions about liver transplant, Jennifer would be very happy to deal with them. So transplant is often in the news, and one of the things, like, there's such a huge opportunity in transplant at the moment. If we look at 2019, which was, before COVID, there was almost 250 life-saving transplants and 25 living kidney transplants that took place. The outcomes in Ireland, we've so much to be proud of. Our outcomes and our transplant rates are among the best in Europe. The rate of lung transplant in the Republic is now 7.76 per million, 6th in the world. And the pharmacist is a key part of this, obviously. And I'm delighted to share some of the learning points with you this evening. And one of the things that's really improved transplant in Ireland is the establishment of ODTI, Organ Donation and Transplantation Ireland. And that's just made everything much more transparent about the number of transplants. And I suppose they published their 2020 figures last year, and you can just see the impact that the COVID pandemic has had on transplant. So that's one of the things that we will mention later. But you can see how transplant numbers in all organs were increasing, and then COVID-19, for a variety of reasons, has reduced the number of transplants. So as I said, I'm only involved really mainly in heart and lung transplant. We do the odd liver here, but Jennifer is definitely the expert in that, and my colleague Bronwyn in Beaumont is the expert in the kidney transplants. And different organs have very different considerations in the balance of infection and rejection. Every centre has different protocols, and the underlying conditions that led to transplant make a huge difference. The other thing as well is that over the life of the patient, their way that they respond to the medications can change. Now, something that came out recently that just really highlights the importance of pharmacists in the care of transplant patients is a recent bulletin from the Institute of Safe Medication Practice from Canada. And they looked at medication errors that involved transplant patients. And the main medication that they found that was involved in errors was Tacrolimus and the other immunosuppressants. The themes that they found that lead to medication variances in these patients is formulation mix-ups, the complexity of care because of the large number of medications the patients are on, which lead to interactions and adverse effects. And the final theme that leads to adverse effects is coordination of care between transitions of care, and which can lead to missed doses or errors in medicines reconciliation. So in order just to highlight ways that we're involved in care, during my presentation, I'm going to talk about immunosuppressive regimens. I'm going to talk about all the reasons why the patients are on so many other treatments, interactions, contraindicated drugs, how we try to promote adherence after transplant, and then the impact of COVID-19 on transplant, a little bit about the new COVID-19 treatments, but with a transplant slant, because that's my interest. So before COVID-19, before we all became experts in immunology and T and B cells and all the rest of it, I used to talk a little bit about what immunosuppression means for a transplant patient. And what we're trying to do is cause organ tolerance by modulating T cells and the B cells. And it's becoming more complex because we're transplanting sensitized patients. We're able to detect rejection by different ways. And but typically the patient that you'll see post-transplant will be having 3 different medications against rejection: a calcineurin inhibitor, either Tacrolimus or cyclosporine, an anti-metabolite such as mycophenolate or azathioprine, and steroid tablets. Now you're going to think that obviously you know that there are other anti-rejection medicines that are used, but when people need to be on mTOR inhibitors or some of the other agents, it's outside the scope of this presentation. We just keep it to the medicines that you'll see the most often. I always show this slide, even though it's from 2004. And again, it used to mystify people before we all became experts in immunology. This is the 3-signal T cell activation model. And it basically shows on one slide where all the medications that we use in transplant work. And the theory of this is that there's signals going back and forth between the antigen presenting cell and the T cell, which are causing a cascade of responses that eventually lead to rejection. And we're using a combination of medicines to damp down this response and stop it amplifying. So the signal one is the one that's blocked by the calcineurin inhibitors, and then the proliferation of activated cells is blocked by the medicines like azathioprine and mycophenolate. And also then on this slide, you can see things that are monoclonal antibodies that are used in the hospital at the time of the transplant to reduce rejection, such as basiliximab. JAK inhibitors have an anti-rejection effect as well, and they're more used in things like rheumatology conditions and whatever. They haven't really found their way into transplant yet. Now you might think to yourself, she said that we're trying to stop B cells being activated as well. And the thing is, in transplant, if you stop the T cells getting activated and prevent them from proliferating successfully, that will actually stop B cells from becoming activated. So even though none of our medicines act directly on B cells, the suppression of the T cells is what stops the B cells getting involved. Now, the mainstay of transplant are the calcineurin inhibitors. And as you know, cyclosporine and tacrolimus are the two we have there. They are, so you use one or other, never both together. They're metabolized through the liver on CYP450, and they have a huge number of interactions through the CYP and P-glycoprotein systems, which we will cover a little bit later in the presentation. But what I want to focus on just in the couple of slides here is about the preparations. So if you remember, one of the issues in the ISMP alert is about mix up between different presentations. And I know with sometimes with the high-tech hub and even with high-tech prescriptions, it's funny that the one drug that the doctors tend to write generically is tacrolimus. And so many times, so all the time I'm training them to write it by brand, but I believe there may be some issues even with hub prescriptions where some of the brands aren't on the hub. So it's very important that you establish which brand the patient is getting, because Prograf should be twice a day. Modigraph sachets, which is a pediatric formulation, is also twice a day. Advograph and Invarsus are modified release once daily. And these two even have different bioavailabilities than each other. And there may also be generics in some countries. And there was a recent article in the Journal of Heart and Lung Transplant where they looked at some people who'd been inadvertently changed to generic versions of tacrolimus and had presented with rejection related to different dissolution properties of the medications. And it's also been, so if a patient is supposed to be getting Advograph once a day and they accidentally take Prograf once a day instead, that has led to failure of kidney transplants. So very serious outcomes. We monitor tacrolimus, so it has a number of side effects: kidney toxicity, neurotoxicity, so shakes, high blood sugar, tremor, headache. They're more seen when the levels are too high. The patient can also get GI disturbance, diarrhea in particular, and tends to make the magnesium levels low, which is why a lot of our patients are on magnesium. We check trough levels, and the level that we're looking for is dependent on the patient, it's dependent on the reason for transplant, it's dependent on the type of transplant, and it's dependent on how long the patient is after the transplant. So all of these medications are sort of, the dosing is dynamic depending on the patient's condition. So you can see it's quite, the trough levels that we're aiming for in heart and lung transplant are much, much higher than the ones that we're aiming for in abdominal transplant. And that's just one of the differences between heart and lung and other types of transplant. Cyclosporine, again, it's very important that it's prescribed by brand, even though, again, the doctors always like to prescribe it generically. And Neoral and Sandemum, there's definitely quite a large difference between those in terms of bioavailability because they're formulated radically differently. And again, like tacrolimus, The levels that we're aiming for are dependent on the time post-transplant, the type of organ, and the patient's characteristics, such as the number of infections they're having or any signs of over-immunosuppression. The side effects between cyclosporine and tacrolimus are very similar. And we used to use, each second patient would be on cyclosporine or tacrolimus. However, female patients, because cyclosporine tends to cause hirsutism, a lot of the female patients didn't like cyclosporine. And it is actually quite noticeable, the difference it makes. Now, the second type of medicine used for as an anti-rejection is the anti-metabolites. So azathioprine and mycophenolate mofetil. And as I said, these prevent the activated lymphocytes from differentiating and proliferating. Now, although they act slightly differently to have this effect, you would only use one or the other, never both together. Their side effect profile is quite different than the calcineurin inhibitors. So you tend to get more things like the bone marrow suppression, very low white blood cells. And that's the reason why the patients are told to report bruising, bleeding, because they can be signs of low platelets and over bone marrow suppression. Azathioprine, we actually tend to find that that's quite well tolerated, but you do have to look out for one important drug interaction with it, and that's allopurinol. Now, that's important because a lot of transplant patients can get hyperuricemia, and it's very easy to start allopurinol or febuxostat, but they both inhibit the metabolism of azathioprine, and the azathioprine dose must be reduced to 25% of the original dose. Otherwise, you can get bone marrow failure due to the exposure. Mycophenolate mofetil is the one that we see more often as the anti-proliferative, and that's probably because it's considered to be a more effective immunosuppressant, and also you can get higher rates of cancer with azathioprine. Mycophenolate, the main toxicity of that is GI toxicity, so people can get diarrhea or vomiting and nausea. If the nausea is very troublesome, then we sometimes try enteric-coated mycophenolic acid. And because that one is released not in the stomach, but in the intestine, it bypasses, it's not released in the stomach, so you don't get the nausea. And the dose is different. So mycophenolate mofetil, the dose is like 500 milligram or a gram, and mycophenolic acid is 360 milligrams because it's not getting broken down in the stomach. The final part of the 3-drug regimen are the corticosteroids. And these act broadly across the T cells. And the great thing about these is that the interactions are not usually clinically significant, but the side effects are. And when I'm doing this teaching with them, with groups of a dozen nurses or a dozen pharmacy students, I always get them to name a side effect of steroids themselves. And there is literally one for everyone in the audience. But the important thing is that, like all of these side effects, we end up having to add another medication to the patient to cover the side effects. So all of our transplant patients who are on steroids end up on a PPI. They all need to be on bone protection for life, no holidays. Diabetes, it adds to the diabetic potential of the calcineurin inhibitors. Weight gain can be a problem, changes in mood, and again, it adds to the high lipids and the high sugars that are caused by the other medications. We do wean down in thoracic transplant to minimize side effects, and in kidney transplant, you're definitely aiming to get the patient off steroids, and that means so much in terms of being able to reduce their burden of other medications. But in lung transplant, it's never really possible to stop the steroids. Occasionally in heart transplant we do, but you can see how much it is to the patient's benefit if steroids can be stopped. because the other thing that steroids are very much part of is the need for antimicrobial cover after the transplant. So in lung transplant, if one of the indications for lung transplant is cystic fibrosis, and a lot of these patients will be on anti-pseudomonal nebulized treatments such as colamycin or tobramycin. And in general, this has to be restarted after the transplant. We also have to cover usually with often have to cover with azole antifungals, which interact strongly. But particularly because of the use of steroids, the lung and heart transplant patients all need cotrimoxazole lifelong. Whereas, in kidney transplant patients where the steroids can be stopped easily, the cotrimoxazole can be also stopped. Because of the steroids, where mycostatin is necessary for a few months, and then also antivirals are needed for at least 3 months post heart or lung transplant, and also post kidney and liver. And which antiviral is needed depends on the patient's risk of either cytomegalovirus or herpes simplex. So if they're at risk of cytomegalovirus, they need valganciclovir, and some of our patients will need that lifelong. And if they're only at risk of herpes simplex, they can manage with acyclovir, which is much easier for the bone marrow to tolerate. The other medications that are important, so I always say to the patients, it's really important that they have a bowel motion every day, because if they're constipated, that will impair their absorption of the immunosuppression. I've mentioned why they need PPIs. All the heart transplants also have to get a lipid lowering agent and aspirin. And that's because one of the ways that rejection happens in a transplanted heart is a thing called coronary artery vasculopathy, where lipid is laid down not unevenly like it is in the normal aging process, but in these little concentric rings that gradually cause blockages in the coronary arteries. This can be prevented by using statins that are targeted against the patient's LDL. Aspirin is also important for the same thing, to prevent these, to try and prevent these blockages. And the heart transplant patients are monitored regularly with regular angios, even if they're young people, to check for coronary artery vasculopathy. Because of the transplant immunosuppression, they often have high blood pressure, and they will need antihypertensive. So particularly calcium channel blockers are used. ACE inhibitors will be used for their renal effects, and alpha and beta blockers. You have to be careful with beta blockers because they can't be used early post-heart transplant. Bone protection is really important, and I feel really strongly about that, because if you think logically about a lung transplant patient, they have huge numbers of risk factors for osteoporosis. Some of them may have been smoking. They don't get out much. They can't exercise much. Their bones are weak going into transplant. The main thing that happens with the steroids is the bone in the spine gets weaker, gets compressed. So the new lung has less space to expand properly, and you're losing, if they get compression fractures, they're losing the benefit of the lung transplant. The other thing then is all the pre-op drugs are reviewed and reintroduced as appropriate. For example, cystic fibrosis vitamins, Creon, antidepressants. Some people think that once they've had a transplant, they shouldn't need psych meds, but it's a really tumultuous time in a person's life, and it's really important that they have all the support that they need, and it's not the time to withdraw the crutch of any psych meds that they need. So what about contraindicated and caution drugs? So number one, no live vaccines, because they can get the infection. No herbal remedies. So these things, people get this idea that, I need to boost my immune system to make me healthier. Like, we're spending a few €1,000s a month on immunosuppressants. They do not need immune boosters. So the advice is you stay away from herbal medicines because they have interactions, and the purpose of them is completely at odds with the transplant medicines. The other thing is we don't want anything which changes immunosuppression levels. So we're always checking for drug interactions. We're checking when a new drug is prescribed, and we're checking when an old drug is stopped, because it's really important not to miss an interaction that might make the immunosuppressant levels out of the range that we want. So common interactions that we tell the patients about, so grapefruit and grapefruit juice. The other thing is ginger, pomelo, pomegranate. I did even have a patient who knew what a pomelo was. But again, these are things that, you know, in small, it doesn't mean they can't have a ginger snap biscuit. It means that they're not to be grinding up ginger, making tea out of it and sipping it all day. Turmeric is another thing that people are quite interested in at the moment, and that interacts. So all of that stuff is out. They're like food is food. All of these food as medicine things, that tends to lead to issues with tacrolimus levels and cyclosporine levels. And one of the things that predicts graft survival is having steady calcineurin inhibitor levels. Herbal teas, they have to be careful with those. Green tea interacts. Anything, a lot of them have grapefruit in them. So mint, peppermint, chamomile are okay, but just stay away from anything else. Definitely no anti-inflammatories. So I always go through that specifically with the younger patients, because, you know, they're hoping to get back to football, they might have an injury, they want to take an NSAID. Now this, if you remember nothing else from tonight, I want you to remember that patients who are on tacrolimus or cyclosporine are not to get clarithromycin. So we're working hard with the company that Astellas to try and get them to change the labeling, the leaflet and the SPC for tacrolimus to make it clear that that combination is contraindicated. They've submitted to the EMA to update the information, but clarithromycin and tacrolimus, you'll end up with a tacrolimus level of about 50, which can end up in hospital and dialysis. It's very, very serious. And clarithromycin, of course, is something that people would always be thinking about prescribing, cover atypicals in a transplant patient. So really important that they don't get clarithromycin. We tell them that. They tell us with tears in their eyes that they will never take it. And every year we have one or two who come in with a huge tacrolimus level and are really sick with it. Erythromycin has the same interaction, but it's much less often prescribed. Funnily enough, azithromycin doesn't interact, and that's okay. Azoles, so fluconazole is kind of unpredictable interaction. With voriconazole, it's a very strong interaction, and we reduce the tacrolimus immediately by 2/3. So if you see somebody starting on voriconazole, they'll be reducing the Prograf immediately. We do warn them about allopurinol and azathioprine. And as a sort of a teaser for later on in the presentation, I'm going to mention Paxlovid there, which we'll deal with a bit later. Now, there's a lot of other interactions. So, you know, it's not just straight drug-drug interactions, but a lot of the drugs we give have overlapping toxicities. So neurotoxicity or tremor, it tends to be, you know, the antiviral, the steroids, and the calcineurin inhibitor all together. We give them about 4 different drugs that cause magnesium wasting, and that's why so many of them are on magnesium supplements. There's quite a few of the drugs that cause increased potassium. A lot of the medicines cause neutropenia and low white cells. There's an additive risk of skin cancer between the anti-rejection medicines and the azoles. And quite an important side effect that's become more recognized in recent years is the risk of Achilles tendonitis with quinolones. So Achilles tendonitis can happen with quinolones, but if you're on transplant medicines, it's much more likely. So we actually do warn the patients about that, because it's really important that they stop the quinolone in time. Otherwise, they can end up, you know, with permanent Achilles damage. When we're talking to the patients, we do go through all this. So the golden rule is don't stop or start anything without checking with the transplant team. We tell them about the drugs to avoid, and that's in their diary. And we tell them not to be getting their medicine blister packed, because it changes regularly, and it's really important that they're in control of their medication. And I tend to find that people with blister packs, they're sort of discounting disconnected from what they're taking. They're not sure. And when we give them an instruction to stop something, they actually don't know which tablet it is in the box. It's really important that they wear the factor 50 because the risk of skin cancer. It's important that their bowels are moving. And if the person has cystic fibrosis, they get additional education about their diabetes management. So that's quite different post-transplant. So what's it like for the patient? So it's something they've been really looking forward to. And it's sort of a whole new world, a whole new paradigm. And it is really, you know, it's quite scary for them because they're going from, you know, the surgery itself is only, we'll say 6 or 8 hours. And then they have the responsibility of lifelong medication adherence and lifelong adherence to the lifestyle. And they're going from, you know, maybe taking inhalers and a small number of medications where if they missed a medication, it wasn't the end of the world, to a huge number of medications that have to be taken at specific times. They might have devices to use that they're not familiar with from before, and they're having therapeutic drug monitoring, and their doses are changing based on their blood results. And it is a lot to take on, and you can see how patients might try and simplify it a bit. And sometimes I hear patients talking about the top 3 medications, by which they mean, you know, their 3 immunosuppressants. But for transplant patients, it's really important that their bowel management is correct, that their food intake and the timing of their food in relation to their transplant drugs, and taking their infection prevention medication, that's all done correctly and as instructed. Because if you're just taking your immunosuppressant medicine correctly, that's actually not enough to get appropriate levels. So if if their diabetes is out of control, the person, you know, is going to have a bad outcome, regardless of whether they take their immunosuppressant medicine correctly or not. Because actually, if their diabetes is out of control, it's impossible to get the calcineurin levels right. And a couple of warning signs that we look out for with the patients is variability in their levels. And so high levels are associated with kidney injury, low levels are associated with rejection. And it's been shown across all organs that the variability, so the standard deviation around the mean, is a predictor, an independent predictor of graft loss. Now, some things that can cause this might be inadvertent change of brands or formulation, diarrhea, constipation, change in food, taking herbal medicines, taking alternative medicine, and managing the diet and the timing of their medication food. So people with cystic fibrosis might be advised to take Creon along with the Tacrolimus or cyclosporine. So we tell the patients to get sort of 6-litre clear box to put their tablets into. And when people come in with something like this, where everything's in order, everything's nicely arranged, and they have their transplant diary. So we get them, they have a transplant diary and they have to fill it in every day with their medicines and tick them off as they take them. If they have a transplant diary like that, we can be very confident that they're taking their medications. Or if there is a problem, we can usually work back and see what the problem is. When we see something like this, where, you know, the medicines are all higgledy-piggledy, there's stuff I dispensed months ago for them, there's new stuff from the pharmacy, and I don't know if you can see it there, but there's Nicorette patches. That's somebody that's starting to struggle. And people that come in with sort of a fistful of tablets here and there and things are out of date, well, they're people that are really in trouble. And that can happen for a whole variety of reasons. You know, the wheels can come off their infrastructure. And, you know, often by the time we see what's going on, you know, they can have done a lot of damage to their graft, and it's very sad to see it. So the next thing that I want to talk about is just the impact of COVID-19 on transplants. So as we saw at the start of the presentation, there is a reduction in the number of transplants being performed, and that's for a couple of different reasons. Obviously, there was a high profile case where, there was a lack of intensive care unit beds to facilitate a transplant. And there's a few other reasons for the reduction in the number of transplants. Another thing I want to talk about is the vaccine response and the new medications and the challenge of avoiding interactions. So there's been loads of different data published about the difference in response in transplant patients compared to the general population to the COVID vaccines. I put this one up here because I liked it because there's two pharmacists on the author list, so I think it's always very good to promote our own. And, there's a couple of issues in that, there's no standardized international measure of antibody response. There's no agreement particularly on what's a protective level of antibody. And at the moment, we don't really have a way of measuring T cell or humoral response. But you can see, like, there's definitely something going on about how low the antibody response is, particularly before the second dose. And certainly our experience here has been that we have had a large number of transplant recipients who have ended up very sick with COVID. Some of them have ended up in intensive care and had prolonged intensive care unit stays, and some of them have died from COVID. And that was we even had people in intensive care who've had 3 doses of vaccine and a heterogeneous course as well, which should be the gold standard of the vaccine doses. So there's definitely a problem. So because of that, we're our advice to the patients is, even though the country is opening up, even though they can travel, even though they can go various places, that they have to follow the old protocols. I think I saw it on one of the HSE websites. It's called Layer Up to Prevent COVID. It's important for them to be wearing their masks, to be avoiding crowds, avoiding travel, avoiding risky situations. And any of the people that are living with them and caring for them need to be doing the same. And I won't labor the fact, but this is why the NIAC advice for transplant patients is that their primary course of vaccines is 3 vaccines, and then their booster dose is a 4th dose. So something a little bit different that you might not have had a chance to hear about so far are the new treatments for COVID-19. And obviously we're really interested in these because, we have patients still ending up in intensive care and still, well, please God, no more of them will pass away from COVID-19. But we're very interested in what new treatments we can access. And I just want to recommend the EMA website. They've got a sort of a dashboard where you can check things that are under rolling review and what status these treatments are at. So there's just a couple of them that I want to cover in the next couple of slides. Sotrovimab, Paxlovid, and baricitinib, and Evusheld. So Sotrovimab is given as an IV infusion. It's 1 dose is the course, and it's allowed now in Ireland for patients who are in Tier 1 or Tier 2 of the clinical prioritization framework. It has to be given within 5 days of symptom onset, and you have to have a positive PCR. Now, I know that you're probably aware that there have been monoclonal antibodies available for COVID for quite some time. There was even Donald Trump had a monoclonal antibody at the time he had COVID several or 2 years ago. What's interesting with the monoclonal antibodies is that you can see there from the little picture, we think that the spike protein is sort of more mushroom shaped with a sort of a stalk and a little cap on it. And some of the earlier monoclonals were very focused on that little cap at the top. And that's the part that mutates the most. So that's why some of the earlier monoclonal antibodies have fallen away, because they're not active against Omicron or some of the newer variants. Whereas sotrovimab is supposed to be targeting a more conserved epitope, so one that isn't mutating as much. So that has had less loss of activity against Omicron than some of the other monoclonals. And what's actually really interesting, it's like a stepping back through time if you look at the SPCs for some of these monoclonal antibodies, because they talk about all the variants that they cover, and sort of like, oh yeah, I remember, alpha and beta and whatever. It's sort of a memory and a worry about what's coming next, I suppose. So we've started using sotrovimab here in the hospital, and we've treated quite a few patients, and so far so good. None of them have ended up needing hospital admission. However, our experience with COVID has been that there's been quite a variation in the transplant patients. Like, some of them have been asymptomatic and some of them have been really sick. So we can't really say yet whether we've been spared with it. Now, I also want to draw your attention to this new one, Paxlovid. This is an oral drug, and it's a mixture of an antiviral that's been developed specifically for COVID and a booster, ritonavir. Ritonavir has a massive interaction with Tacrolimus. The American instructions or information for Paxlovid doesn't contraindicate it with calcineurin inhibitors. However, the advice from the specialist pharmacist service in the UK is not to give it. And we would agree with that. We don't want to be giving Paxlovid to our patients who are on calcineurin inhibitors due to the huge rise in levels that will happen with ritonavir. What's the other thing that's interesting about Paxlovid is that it's been trialed in unvaccinated populations. So whereas sotrovimab, that was found to work better in people that had either been exposed to the virus before or had been vaccinated. I mentioned this drug because it's just interesting that it's a repurposed drug. It's a JAK inhibitor that's used in rheumatology. It will have an interaction with cyclosporine most likely, and with voriconazole. But JAK inhibitors are potent immunosuppressants in their own right, so we don't see that this is going to have an important role in transplant patients. This drug here was developed as for Venezuelan equine encephalitis, so it's been repurposed as a veterinary drug. And what it does is it causes copying errors in the COVID virus. There is some worry that it might lead then to more development of mutants, but we don't know very much about the effectiveness of that one yet. This one here is another monoclonal antibody, and at the moment it's being assessed for pre-exposure prophylaxis. So I don't really know how that would, we wouldn't really have the capacity probably to be doing pre-exposure prophylaxis for all our transplant patients. It has, interestingly, it's contraindicated if a person has more than 2 risk factors for MI, and most transplant patients would have more than 2 or more risk factors for MI. So this is probably one that won't be useful for transplant patients. So in summary, during my presentation, I've talked about the different immunosuppressant regimens. We looked at the Institute for Safe Medication Practices, the areas where pharmacists add value to these patients' care. We've looked at contraindicated or cautioned drugs. We've looked at the impact a bit of COVID-19 on transplant in terms of vaccination, and how unfortunately they still have to live like it's January 2020 or 2021. And we looked at the new treatments for COVID-19. And I always say in my presentations that the successful transplantation is a multidisciplinary achievement, and all pharmacists have a key role in the team. I always do a few acknowledgement slides at the end as well. So this is one of our patients. This photo was obviously well before COVID was a thing. And this lady we had a little award ceremony for her because she's for 30 years, surviving 30 years after her lung transplant. And that's the great thing about transplant. It's sort of the ripple effect. You know, this is a lady who was able to see her grandchildren, her children getting married, her grandchildren being born, her grandchildren being teenagers, you know, and it brought a lot. It's, you know, we've loads of stories like that in the transplant team, which is why it's lovely to work there. And I never finish a presentation about transplant without acknowledging donor families. So none of it would be possible without donor families. So those are two of our patients who are really great advocates for donors and for having that conversation. And that's the end of my slides. So I'm very happy to take any questions that anybody has.
Thanks a mil, Patricia. That's really interesting. And yeah, it's really brought it home to me looking at those pictures there, you know, how impactful this is on patients' lives. And I think thanks for bringing that to the forefront at the end of it. So we have a question that's come in during the course of the presentation. So it's about, sorry, now let's get my bearings with it, about missed doses. So say if, for example, a medication is 12 hours late, are there recommendations on what to do? I suppose it's obviously quite drug dependent, but do you have any pearls of wisdom there?
Well, it's sort of a tricky one because we can't be saying to patients, well, it's okay to miss a tablet. And it does depend on the medication. So what would be, like, one of the things is we ask them to ring us. So what can sometimes happen is the patient can, you know, get sick very soon after taking medication. And it depends on the medication, it depends on when they got sick. So that'd be really, we would individualize it very much, because we'd be very, you know, if somebody got sick, we'd like them to ring clinic so that we can advise them specifically, and also so that we can prescribe antiemetics or review them. Because if they're getting sick, for example, you know, it might be a sign of something else, because we had patients who were getting sick who didn't want to bother us during COVID, you know, who had really severe infections. And if we hadn't rung them about something else and discovered this, you know, they would have had a really bad outcome. So we're really, like, the communication is so important.
Yeah. So this is a question come in about the presentation and whether this will be shared. So we've recorded this and that will be posted to the website afterwards. So hopefully that answers that question. We have another one come in. Sorry, a few coming in, so I'll just try and keep up with them.
So there's one there from Orla saying, could it be mandatory to have a contact phone number on a high-tech prescription if meds are changed, or to write that on the prescription for confirmation? So I thought on the high-tech prescription, the unit phone number is supposed to be on it, but certainly the patient has the unit phone number and the direct line to the clinic nurses and also, you know, I would be confident that it always happens, that if we're changing their medication, that it is explained to them and that they should be able to tell us. So we would be interested to know if they hadn't taken that information on board. But I thought the phone number is on the high-tech script. I think somebody's asked about a sugar-free mycostatin. I don't believe there is, but there was talk about discontinuing mycostatin, so I'm actually grateful that there is any. Really, our patients should only be using it for 3 months, unless they have some particular problem with, you know, with augmented immunosuppression and thrush.
Okay, a few coming in. So the website you mentioned about the new COVID therapies.
That's the EMA website. So actually, if you just Google EMA and COVID treatment. We've got one here about the management of drug-induced hyperplasia. Yeah. So do you mean gingival hyperplasia? So we usually just, like most of the patients, will be on chlorhexidine mouthwash for gingival, well, it's to prevent mouth infections, but actually we don't see a lot of gingival hyperplasia with tacrolimus, possibly a bit with cyclosporine. I think a dose change should be scripted. Ray's just asked, should dose changes always be scripted rather than verbal advice? I mean, sometimes it will be verbal advice and the script will follow. So somebody's asked about drug interaction between tacrolimus and augmentin. We haven't seen any change in tacrolimus levels with concomitant augmentin. So there doesn't appear to be a clinical interaction there. There is one reported between augmentin and mycophenolate, but again, that's not clinically significant for the short course of treatment.
Drug repurposing in COVID-19. I think you mentioned a little bit about drug repurposing as you went.
Yes, so so like the monoclonal antibodies have been specifically designed for COVID, but it's one of the interesting things about, you know, modern drug development, that people are able to look at the shape of a molecule and the targets and then come up with things that might interfere with that interaction. The repurposed drugs haven't really been very successful. So, you know, there was use of the drug for one of the HIV drugs was trialed for COVID, but it wasn't successful. Hydroxychloroquine was trialed for COVID and it wasn't successful. So really the repurposed drugs haven't been particularly effective. There was some effectiveness from tacrolimus in certain patients who were, you know, extremely unwell in intensive care, and that was useful for them. But I think in general, the repurposed drugs haven't been particularly good.
I have a question, if you don't mind, about obviously there is a huge number of kind of lifestyle dietary interactions that you touched on, about the, you know, obviously that's going to be a lot of information for a patient to keep track of, and how do they manage that information? Are they given a booklet, or how does that go?
Yeah, so they are given a booklet, and they're given a booklet actually at the time of assessment for transplant. So a booklet that they can take away, read with their family, and to see if this is for them, if they think that, you know, they'd be willing to do these things. Education post-transplant starts early. I would do maybe 10 minutes per day with people, because they're not often able for much more. And you're doing 10 minutes per day for, you know, every day that they're in hospital. So they're getting, you know, an hour or 2 hours of education from me before they go home. The dietitian gives them certainly an hour or more of her time. The physiotherapist, they're doing exercise with the physiotherapist from the time their eyes are open. They're getting this information repeated as well in clinic. And we've recently updated we've recently done a new pack with education for the patients. We also do master classes for them as reminders, because it's easy for people to sort of slip, you know, to slip back into older habits, or to get a little bit lazy as the weather gets bad. And we just, you know, just to try and encourage them.
Yeah. A few more come in here. Remdesivir. They're saying NICE suggested in immunosuppressed patients. And then there's another actually comment on remdesivir as well. Remdesivir and COVID in transplant patients.
So we actually had very few that received remdesivir, and I think it's not particularly being used now. I think people have moved on. And I think the data from the, you know, the studies in the UK, it was very marginal benefit.
Question about compliance aids or blister packing. Do you think there's a place for them? Yeah.
Yeah, I mean, the odd patient needs it and really does benefit from it. What we're trying to get through to the patients is that you actually do have to make a solid effort to learn the medicines and to take control of it, and not just to think, because sometimes people say, oh no, it's grand, I actually don't need to learn about the medicines because my wife does everything, or I don't need to learn about the medicines because my pharmacist put them in a little box for me, that's grand. And we're trying to get the message that actually isn't the way to do it. We have a number of patients who over time, like I remember one who had a stroke and he couldn't manage all the tablets, and they were in a compliance box, but because he'd managed them for years and years and years, he knew everything that was in there. And if the pharmacist made a mistake, he knew the wrong tablet was in the wrong spot. And that's the kind of thing that, that keeps a patient safe. And the other thing then that we, if somebody's using a compliance aid before transplant, that's kind of a warning sign that medicines, they're not giving them the kind of importance that they need to have, or they're thinking that, actually, this isn't, they're kind of not engaging with learning the medicines. Because I tend to find the people who have a blister pack, a lot of them can't tell me what they're on. They don't know why they're taking it. And that's the risk that I see with those when they're used, for everybody. Whereas I agree with whoever MD20 is, there is the odd person who does need it, and we will ask for it if we think somebody needs it or would benefit. Somebody's asked about guidance with generics of mycophenolate. So we're not asking that particular brands be given. We haven't found any issue with generics. So somebody's asked about mycophenolic acid and COVID. So I didn't get into that in the presentation, but our practice was generally to stop the mycophenolate in patients who were admitted to hospital with COVID. But that's interesting that the SPC has been updated with that. And we wouldn't directly, I don't know if you're asking about augmenting with other immunosuppressants, but we wouldn't do that. We just literally stopped the mycophenolate because it seems to be the one that has the most effect on COVID trajectory. Somebody's asked about dexamethasone in COVID positive. So the guidance from the Irish Department of Health was that if you were on regular prednisolone, you didn't get dex, you got prednisolone instead at an equivalent dose. So that's what we did. We gave prednisolone. We didn't give pred and dex.
Thanks for that. We're really using all your knowledge. It seems like you're on fire. It's brilliant.
Well, I just say to people, like, you don't have to take all this in. Like, if you're working in a hospital and there's a COVID positive patient, we want to know about it. We want to be helping you out with how they're managed and giving advice that's specific to the patient and answering all your questions. Don't feel like you have to listen back to this and start writing a million notes and managing the patient according to that. We're absolutely we're determined, and we really want to hear from you. And if you're in a community pharmacy and you have a question, we want to hear from you. Ask the patient when they come in, first of all, what is the clinic number? And my colleague Jennifer in Vincent's Hospital, she said exactly the same. I emailed her before the presentation. I said, is there anything you want me to tell people? And she said, I'm really happy to take questions and we will help out in any way we can with the patients.
Yeah, I was just going to, obviously you've given loads of really useful information there about things to think about, compliance aids and, OTC medicines and lots of different, potentials for interactions. What are the kind of key things that you think, that difficulty we have across the care interface between secondary care and primary care and easing that transition and making sure it's all smooth? What are the kinds of things you think community pharmacists should keep in mind when engaging with these patients?
Well, ask them. And if you're not happy with your answer, ring us. That's fine, because we have all our patients have a clinic folder, and in the clinic folder, the first thing on the front is the patient's community pharmacy, phone number and fax number, so that we can contact you. You can contact us. So if you're worried about something, and just ring and check, because it's not easy, and there's a lot to take, and we're not perfect, and we do make mistakes, and I do review the discharge prescriptions of as many patients as I can, and I do try to look at it from a community pharmacist's eyes and try and have it right. But there's a limit to how well I can do that. So if it's not right when it gets to you, just ask.
Thank you. I think we've kind of worked through our questions, so thank you so much for that. I learned a lot, and yeah, it's been an eye-opener for me this evening, so thank you. What I'm going to do now is I'm actually going to pause the presentation, and if anyone would like to unmute